at the University of Arkansas for Medical Sciences. And so this evening, I'm going to present a presentation on kind of an overview of the prostate cancer in Arkansas, going through the epidemiology, the screening methods, and availability of care in the state. So a little bit about me. I graduated from the University of Arkansas in Fayetteville with a Bachelor of Science in Chemistry. Currently, I am a Master of Public Health student at UAMS, and my research interests lie in cancer epidemiology and public health, specifically in screening availability and outreach, and focusing on prostate, lung, and breast cancer. So I want to talk about a little bit of the epidemiology of prostate cancer, what new cases are looking like, who's being diagnosed in the state. And before I begin, I would like to go over some of these diagnosis stages for people who are unfamiliar with them. So local diagnosis is a prostate cancer that the tumor is localized on the prostate gland and it has not spread to any other tissue areas. Regional diagnosis is where tumor has spread from the prostate gland to nearby tissues or lymph nodes. And distant diagnosis is commonly what we say as metastasized, where the tumor has spread to lymph nodes and has moved across the body. Prostate cancer really moves primarily into the bone, in the spine, or in the liver. And finally, unstaged cancer is simply a cancer diagnosis with not enough evidence to warrant a staging of local, regional, or distant. So it could be a very small amount of cancerous cells, but it cannot be staged as a prostate cancer local, regional, or distant stage. So in Arkansas, prostate cancer is the most diagnosed cancer in men yearly. Arkansas has more prostate cancer cases per year than the national average. And local diagnosis is the most common stage of diagnosis. So cancer that is non-life-threatening and has the most active surveillance or treatment options. So who's getting prostate cancer? What ages are people being diagnosed with prostate cancer in Arkansas? Well, we see that men aged 70 to 74 years old have the highest rates of total prostate cancer, of new prostate cancer cases in Arkansas. And really, men aged 60 to 80 make up the majority of new prostate cancer cases. And as you can see in this figure, really, the incidence rate for newly diagnosed men really increases tremendously from 45 to 50, and even from 50 to 55. So we really see a large increase in new cases the older people get. So this figure here shows the new prostate cancer cases by age group and stage of diagnosis. And some key takeaways from this figure are that men aged 70 to 74 have the highest rate of newly diagnosed local prostate cancer, so the prostate cancer that is localized on the prostate gland. Men aged 65 to 69 have the highest rate of newly diagnosed regional prostate cancer, so that cancer that has spread to nearby tissue. And men 85 and over have the highest rate of newly diagnosed distant and unstaged cancer. So the cancers that have spread across the body or the cancers that do not have enough clinical evidence to warrant a stage. So how many people are living with prostate cancer and what are the survival rates looking like? So more than 9,000 men were living with prostate cancer in Arkansas between 2013 and 2017. And over 1,300 men died from prostate cancer between these years as well, which accounts for about 7.6% of all cancer deaths. And these are deaths from prostate cancer and not someone living with prostate cancer who died of a heart attack. So these are directly attributable to the disease. And in this table here, I think has a very good story in that really distant prostate cancer diagnosis has the lowest 5-year survival rate. So what this means is that someone diagnosed with distant cancer really has about a 33% chance of actually surviving the disease over the next 5 years. And also what this table points out is that detecting cases earlier at earlier stages leads to higher survival rates. So at a local diagnosis, the diagnosis where the tumor is only on the prostate gland has a 5-year survival rate of 100%. And even with regional cancer, it only falls to 99.2%. So we definitely see better treatment options, better active surveillance options, and a better survival percentage for earlier diagnosed stages. So what are some risk factors for prostate cancer? Well, they primarily fall into these two groups, which are person-specific or individual factors and environmental or behavioral factors. So these person-specific factors are family history or genetics, race or ethnicity, and age. And the environmental and behavioral factors fall into diet, occupational or environmental exposures, such as chemicals at work or pesticides in farming. And then also lifestyle factors such as smoking or physical activity. But really, out of these risk factors, there's the three main ones, and this is what the research mainly focuses on: is family history, genetics, race or ethnicity, and age. So having a first-degree relative, such as a father or brother diagnosed with prostate cancer, increases your own risk of prostate cancer by more than twofold. And also a familial history of prostate, breast, or ovarian cancer indicate increased risk of prostate cancer due to genetic mutations. And for race and ethnicity, African American men have higher rates of prostate cancer diagnosis than European American men. And there are a couple reasons for this, hypothesized reasons. It could be due to genetic differences or access to care. We see that more European American men are receiving screenings throughout their life. And age, as men get older, their risk for prostate cancer increases naturally. And this can be said of all cancers. The older we get, just the more likely we are going to develop cancer. And so, what are some protective factors? Definitely in the cancer world, we focus on a majority of risk factors, some negative factors. But I wanted to highlight some things that you can do to try and reduce your risk of prostate cancer. And really, only modifiable risk factors can be changed to reduce your own prostate cancer risk. So, dietary changes, such as eating more leafy green vegetables and fruit, and really decreasing your amount of well-done meat, among other things as well, to reduce your prostate cancer risk. Lifestyle changes, such as stopping smoking or decreasing alcohol use or increasing your physical activity, can also reduce your prostate cancer risk in your lifetime. And then environmental and occupational awareness. And I say awareness because often you are not in control of what you are exposed to in the world or at work. So it's really important to, wear proper PPE when at work. If you work in chemical plants or manufacturing plants, or if you work in farming, it's important to be aware of what exposures that are at your work. So risk factors such as age, race or ethnicity, and family history and genetics, the big three that we've talked about, are non-modifiable. So these factors can't be changed. You can't change your race. You can't change how old you are. For individuals with these factors, they really are the high-risk group. So there are the two most widely accepted prostate cancer screening options include the prostate-specific antigen testing and the digital rectal exam. And Probably most of the men joining today know what these screenings are. You have likely had them before in your life. But for everyone else, I wanted to kind of describe what these are. So the PSA test is a blood test which looks for a specific biomarker excreted by the prostate gland called prostate-specific antigen. And so this antigen should be present in the blood in a very small amount. So what we see with this test is that individuals with high levels of this biomarker in their body, there could be an underlying cause for this. It does not mean prostate cancer, but really it could mean overexpression of the gland or changes as you age, or an infection as well. And then the DRE test is the test where a physician inserts a gloved finger into the rectum to actually feel the prostate glands, to feel for any nodules, lumps, irregular texture, irregular shape of the gland, or feeling for any tumors on there as well. So both of these screening methods are covered under Medicare and Medicaid once yearly. Men 50 and older on Medicaid until they're 65, and men 65 and older on Medicare until they're 75 years old. So I want to go through in detail kind of the early detection guidelines, what men need to go through before they receive a prostate screening, and the categories that these screenings fall into, specifically for PSA testing. So the National Comprehensive Cancer Network Clinical Practice Guidelines in Oncology provide updated guidelines for all cancer types, including the early detection of prostate cancer. And essentially there are 3 different stages of early detection. There is a baseline evaluation, which consists of a history and physical with your physician, a risk assessment, which is a conversation with your physician about risk and benefits of PSA testing, and then also a baseline PSA or a baseline DRE to assess your lifetime risk for prostate cancer. And then early detection evaluation, which categories do you fall into, and how do we determine cutoff points for your PSA score? So there are 2 categories of individuals eligible for early detection evaluation. Category 1 includes individuals aged 45 to 75 years old for average risk, and the individuals aged 40 to 75 for Black or African American individuals, those with genetic mutations, or those with suspicious family history. So those 3 main risk factors we talked about are really what put people in the high-risk population for prostate cancer. Then the second category are individuals 75 or older. And this is a different category because PSA numbers do increase as age naturally. So for category 1, there's 3 basically cutoff points for when you would have repeat testing. So PSA under 1 nanograms per milliliter, and a normal DRE, if done, warrants repeat testing at 2 to 4 year intervals. A PSA of 1 to 3, which is in normal range, and a normal DRE, if done, would warrant repeat testing at 1 to 2 year intervals. And then finally, a PSA above 3 and or a very suspicious DRE warrants further evaluation and imaging or biopsy with a specialist. And then for the category 2 individuals, which are those 75 and older, the PSA cutoff point increases to 4. So people with a score under 4 and a normal DRE if done, and no other indications for biopsy warrant repeat testing in select patients at 1 to 4 year intervals. And then people 75 and older who have a score greater than 4 or a very suspicious DRE examination would warrant further evaluation or imaging and biopsy. Or individuals over 75 may elect not to be screened. Prostate cancer may not be affecting them in their lifetime. So what are the benefits of screening? PSA screening helps detect late-stage prostate cancer cases that would otherwise go unnoticed until symptoms appear. Prostate cancer is a disease that really shows no symptoms until it's a late stage. So when you do have symptoms, it's pretty far spread as well. For high-risk men, baseline screening in their late 40s or early 50s can help assess their prostate cancer risk in their lifetime. And PSA testing is not a diagnostic criteria for prostate cancer, but it can lead to early detection of prostate cancer before late-stage metastasis, which is where the majority of prostate cancer deaths occur. And if you remember back to our earlier slide, where the lowest survival percentage is. And the only diagnostic criteria for prostate cancer comes from imaging or biopsy, and specifically biopsy with a pathologist. So what are the risks of prostate cancer screening? These include overdiagnosis and overtreatment. And overdiagnosis is defined as a asymptomatic cancer detected with a tumor that will not progress to later stages during the man's lifetime, or it will progress at such a rate that will not cause quality of life harm or significant adverse health effects. And overtreatment is defined as treatment of cancer that would cause greater harm to quality of life than not treating the cancer. So overtreatment, an example may be an individual aged 85 years old with a early stage prostate cancer. This cancer probably will not kill them. So physicians may elect to do active surveillance instead, where they, yearly, every 6 months, may check up with a patient to assess how their prostate cancer is progressing and if there would be any need for treatment. So it is important to talk to your physician or your healthcare provider to discuss your personal risk factors and if screening is appropriate. And so what are some barriers to screening? And what I mean by this is what's stopping people from receiving prostate cancer screenings? So these include a lack of knowledge about the screening methods, about DRE testing or PSA testing, about prostate cancer itself. What is the disease? What is the prostate gland? Many individuals do not know these things. And then about the prostate cancer risk factors. So the main three that we talked about, family history, race, and age, they may not know their personal risk factors and if they're at increased risk of prostate cancer. There's also a lack of transportation, a lack of access to healthcare, a lack of insurance coverage, and just a general distrust of medical professionals. So these two figures here, I think, have a very telling story. On the left, we have the prostate cancer incidence rate, which is the newly diagnosed cancers in Arkansas from 2014 to 2018. And darker colors mean more incidence. And the figure on the right, we have the number of Arkansas urologists per county in 2020. So if we see in the incidence rate figure, our shading really gets darker in the middle of the state, moving to the southeast near the Delta. And at our Arkansas urologists per county, the majority are located in Little Rock and some of the other urban areas in Arkansas, such as Fort Smith, Jonesboro, and the Fayetteville area. But we do not have any in the south or southeast, where we have the highest incidence rates. So this really is a problem because many of the individuals living in the Delta do not have access to take a day or 2 days off work to come up to Little Rock to receive a screening or a biopsy. So that's something that I think that the Prostate Cancer Foundation does a really good job of, is we go to these communities to try and increase their screening rates. So one important aspect that we do here at the Prostate Cancer Foundation is prostate cancer education, health education to communities and individuals. So we have peer network meetings, our social media, flyers and pamphlets at events, and our newsletters sent out monthly or sometimes weekly for special cases. So we have here at the office and at our screening sites pamphlets describing treatment options for prostate cancer, the urologic providers in their area, patient support, and also treatment side effects that are available to all men for free. And we also have Kara, our patient navigator, who assists men in finding treatment centers and physicians to help them interpret their screening results and providing important follow-up information with these men we help screen. We also have 2 programs here that we have to further health education and help the foundation as itself interact with the community. We have the Champions program, which was started in 2016. And this program consists of group meetings with prostate cancer survivors, newly diagnosed men, and those currently in treatment or remission. And this really brings community members together to provide support and information with each other. And this is really important because no one expects to be diagnosed with cancer. So this can be a pretty daunting time for an individual. So it's really helpful meeting with people who have gone through these treatment options, who have been diagnosed with cancer, and finding support with them. We also have our patient advisory program, which is an advisory committee comprised of prostate cancer survivors, their family members, and anyone who's interested to assist the Prostate Cancer Foundation on the screening and educational needs in their communities. And this advisory program also helps us make sure our educational material utilizes plain language, which is important for some of these health terms that may be very confusing to individuals who are not, do not have high health literacy. So one thing I think that the Prostate Cancer Foundation does very well is a community-based outreach. So healthcare providers and organizations really need to adopt a consumer community model of outreach concerning prostate cancer. So what this means is really working with non-healthcare sites, such as churches or religious centers, work sites, plants, factories, and housing complexes as well. And again, as we stated, the high-risk population are the men that have these prostate cancer risk factors and are not receiving routine screening. And as I said earlier, without screening, prostate cancer is only detectable once symptoms start in a majority of cases. And so these include difficulty or frequent urination, difficulty having an erection, blood in your urine or semen, or a sudden onset of pain in your back, hips, or thighs. And that's a tough one because as you get older, you do have a lot of pain. And I feel like that nowadays sometimes as well. So where should we target screening in Arkansas? Well, ideally, we want to target the sites with the high-risk male population that are not receiving the routine screening, specifically in the Delta region where we see high incidence rates of prostate cancer. So the factories and plants have a large majority of male workers that are older, religious centers such as churches, and community centers such as senior activity centers. So we really want to work with community leaders to identify the high-risk groups in their population because we're only one organization in Little Rock. And these people across the state know their community better. And we really want to work with them and say, who in your community is going to benefit from these screenings? So working with pastors or religious leaders and working with their congregation, who in their congregation is not receiving screening, who would be eligible for it. Working with employers to look at their coworkers and employees. If they have a high older male population that do have risk factors for prostate cancer, would that be something they would be interested in having? And then also community leaders, family members, and friends. I know that one thing is family members as well, and especially if you have a family history and you know people that have a family history, really getting the word to them about considering prostate cancer screening. And we also want to collaborate with other health organizations across the state. This is something that we do already with hospital networks such as Baptist Health, St. Bernard's, Unity, Arkansas Urology, among a host of other hospital networks. And we also want to work with local organizations such as the Arkansas Minority Health Commission. And we do screening events with them throughout the year. And really, we offer more than just a prostate cancer screening. We offer cholesterol checks, blood pressure checks, A1C, and really this is what draws people to screening events, is that not just prostate cancer itself, but offering a wide amount of, you may not want to get screened for prostate cancer, but would you like to get your blood pressure checked? So really increasing what people know about their own body, and that's really important. So what's the future research in Arkansas looking like? Well, we really want to focus on the availability of care and addressing these barriers to screening, especially in the Delta region. And we also want to focus on the rural areas and communities to increase the availability of not only urologic care, but also screening. And really targeting the high-risk individuals, because these are the men that are going to have those late-stage diagnoses if they're not getting screened. So what are some take-home points? Well, prostate cancer is most diagnosed in men aged 60 to 80. There are men that get diagnosed earlier in their maybe 40s, even 50s, and really the majority of cases are later in life. Early stage diagnosis or local diagnosis is the most common diagnosis of prostate cancer, which does lead to more treatment and surveillance options than late stage diagnosis. When you are diagnosed with late stage cancer, you are pretty limited in what your options are moving forward. Prostate cancer screening is an important tool to assist in catching cases earlier rather than later. Of course, these screening methods are not diagnostic criteria, but they do allow us to keep tabs on individuals and not only their risk for prostate cancer, but catching it earlier rather than later. And we also want to increase health education and provide targeted screenings in high-risk populations here in Arkansas to really let Arkansans take control of their own health, to be aware of their own health, and to raise awareness of this disease because this disease is real and it affects many lives every year in Arkansas. And finally, I would like to thank the Arkansas Prostate Cancer Foundation staff, the Arkansas Department of Health, and the UAMS for giving me the opportunity to present on this important issue facing our men in Arkansas. And I would also like to thank all of you joining in person here today and online for spending time to listen and learn about how prostate cancer affects our state and what we can do to better our own health and increase our own health education. And I would also like to add one more thank you to Ms. Kara Clements, who has been here for over 10 years and has done a fantastic job raising awareness and helping these men navigate their journey through prostate cancer. So a round of applause here in person and online for Ms. Kara.
Okay. Do you want to ask if anybody has any questions?
Yeah.
Since I know I have a few private, so.
Oh, it's in the chat.
Yeah, you can see. Okay. Hi, everybody. Does anybody have any specific questions for Edgar before we open up our regular prostate cancer support group? I thought I had one. Good job, Edgar. I thought Edgar did a great job. He's been with us for over 200 hours now, and we could not have survived September without him. September is Prostate Cancer Awareness Month, and it was insanity. And he was there every step of the way with us. So we couldn't have done it without you. And you've been great. And this has been such a good presentation for us. So if anybody has any questions, you can shoot it in the chat. If not, you can always email me at the foundation and I'll connect you with Edgar. Yeah, great job. Everybody's proud of you. And so my email address is cclements, so that's CCLEMENTS at arprostatecancer.org. So you're more than welcome to shoot me an email. If you are part of our regular support group, I will encourage you to stay on. We'll have our regular open meeting. If you are not, then I ask that you hop off, because this is just where our survivors kind of meet and update us on what's going on. And I want to thank everyone so much for participating today. And we hope that you continue to support our organization and all the efforts that we do to help men throughout the state with prostate cancer awareness and survivorship.
So any questions? Here in the audience, any questions?
Anybody?
I have one, but I'll ask it later.
Everybody's so nice.
I mean, I'm always good for a question. I can ask one that came to mind. You talked about the 3 different things that affect people's risk was family history and age and race. But then when you show the map, the distribution is mostly geographically southeast. And I know that just demographically, we have a older population, like just the age structure is a little bit older in the north central part of the state, but it's not reflected in the prostate cancer rates. I'm just curious if that's an anomaly or if there's some pattern behind that.
So I think on the map, the county that Hot Springs is in, is it Hot Springs?
Mm-hmm.
Yeah, it does have a high incidence rate there as well. We have
And northwest in like Bentonville, which is, can you pull that slide back up?
Yeah.
Which, we have a higher retirement community in Hot Springs Village, as well as Bella Vista. So I was going to pull and see that because I think we noticed that one. Oh, yeah. So we've got a pretty, I forgot yours is a touch. Sorry. So per population, in those areas, that's a pretty high incident rate. It's not as high, but I don't know. What would you say?
There is, I think, pretty high incidence rate of prostate cancer across Arkansas. So from the graph, we see that the lowest is 59.5. It goes all the way up to 185.2 per 100,000. And so some of this may be that some counties do have a lot more people than others. For instance, like Pulaski County, we have a bigger population than some of the parts in the southeast and northern Arkansas. So this could be just a statistical anomaly, just based on how many people are living in the county.
Does that help answer? There's a big question came in from Cosley.
Can you read it?
Yeah, there are so many areas of the state that have no urologist. I understand the outreach that is done by the foundation. Does your research indicate any interest among the professionals to get into these areas, if for no other reason than humanitarian purposes? So I will say that I do know that Arkansas Urology has opened satellite clinics. I don't know if they can hear me, in different areas.
I know where you're going.
Yeah.
So Arkansas Urology and UAMS do have satellite clinics across the state, really to try and increase the care in these rural areas. I know Arkansas Urology opened up one in El Dorado and maybe Monticello as well. So they really are trying to bring providers into those areas, but they are not there full time.
Treatment is not available.
Right.
Now it helps to transition from not having to travel so far, every appointment for follow-up care, but it is, as far as primary treatment and receiving treatment, you still have to go to a bigger city where treatment is available.
Right. And if people online couldn't hear that, essentially, even if providers are down there temporarily to increase maybe DRE screenings or care. They still, individuals in these areas still have to travel to, for instance, Little Rock to receive treatment for prostate cancer. So it's
Carti also has facilities for radiation. They have radiation centers that are popping up. UAMS has really good satellite clinics for just wellness clinics that are opportunities that you could go see a provider there instead. But it's just you're limited for actual treatment. And that's one of our big things. And that's where we have a patient access to care program. So we provide gas cards as well as hotel assistance, travel assistance, and even
you can sit over here in this chair.
well, okay. I mean, yeah, but as well as so. Yes and no, Causely. So we have a patient access to care program that provides assistance for patients so they can actually travel for treatment, such as gas cards, hotel assistance, and then even bill pay assistance so they can receive the treatment that they need. We don't want anyone to forego treatment because they can't either afford it or they can't travel to a location where they can receive it. So we try to be a full circle of care facility. So we're not just going to go out and leave somebody somewhere where they can't receive treatment if they have a diagnosis.
This thing's over. I'm getting ready.
And that could also be applied to maybe why some people are electing to not receive screening. Because
we got a lot of things
don't
to do.
want to be diagnosed with prostate cancer because it is an expensive
I
treatment.
like to spread it out
It
here.
is expensive
And I like
for biopsies. I'm not muted, am I?
No, you're not. But somebody was unmuted, and so we could do that.
I'm not muted.
No, you're not. Yeah, you're good.
Okay. But yeah, so it is a really expensive disease. So especially people who are underinsured or have no insurance, and those are really usually the high risk individuals that are not receiving routine screening, may elect to not be screened because they just really don't want to be diagnosed with it. And they really, it doesn't matter if they have the disease or not.
Thank you for everything, and I'm sending out a final.
Okay.
Just tell them to check the chat for an email address, and we will.
But thank you everyone for participating, and again, thank you to everyone who has helped me here at the Arkansas Prostate Cancer Foundation, at the Department of Health, to provide the data you saw in the presentation, and at UAMS for allowing me the opportunity to work here this semester and to bring you all this information.